and how many times do you have to do it over and over again to make sure you get it right?
To get it right. Hey, Sunil, should we get started?
Let's do
What do
it.
you think? All right, so kick us off.
Welcome to everybody. COBRA, the combined rounds from Stanford and the Cole Institute. Sunil Srivastava. We got some great cases. Let me just first thank our sponsors, Bausch & Lomb, for their continued support of COBRA. Welcome you all to the second one of the year. We will have COBRA live at the Academy, and we'll talk more about that in a second. Prithvi, take it away. I think you guys are up first.
That's right. So I'm Prithvi Mruthyunjaya from Stanford, and I am pleased to introduce one of our first-year fellows, Lucy Guo. Lucy did her residency here with us at Stanford and has been doing an amazing job in her surgical journey with us. So today the theme, if you all didn't hear, it's all about peeling. So we're going to look at some macular cases, which will be similar, but I think we're going to learn a lot from each of them. So our mentors tonight from the Stanford side, Loshan Liang. Loshan's one of our former fellows, but now is an old man. He's an assistant professor of ophthalmology and directs our VA retina service, which is incredibly busy, and the ever awesome Dr. Carolyn Pan, who is an associate professor of ophthalmology and our residency director, and leads our Santa Clara Valley Medical Center Retina Service. So with all these illustrious titles following you, Lucy, take it away.
Awesome. Thank you so much for that kind introduction, Dr. Mruthyunjaya. So thank you everyone for being here. My first COBRA, watched a lot of these as a resident, so it's finally interesting to be on this side of things.
So you're gonna regret this, by the way, just letting you know.
Probably. The dread is already rising. So we're presenting a case of a chronic macular hole that I did with the illustrious Dr. Diana Doe a couple weeks ago. So this is a gentleman, a 57-year-old male with blurry vision in the left eye. He says for the past 6 months, only medical history was chronic myeloid leukemia, for which he was getting treatment. His vision in the right eye was 20/25. The vision in the left eye, which is the symptomatic eye, was 2600. He says that it's been like this for the past 6 months. IOPs were normal. He was phakic, 1+ NS in both eyes. On DFE, the significant thing that was noted was that he had a macular hole in the left eye with some edema. So these were his OCTs from his pre-op appointment. You can see here the right eye, the hyaloid is still attached. Foveal contour is unremarkable. In the left eye, the PVD is present, and there is a large full-thickness macular hole that we draw attention to, with some associated cystic changes. And also there's a central transmission defect, as you can see from likely loss of the RPE, that layer. Went ahead and measured this macular hole. So here you look, if we look at the smallest diameter from each side of the macular hole, it measures about 500 microns, which would be considered a large macular hole in this case, and also measure the base diameter as well. And then this has been going on for some time, so at least 6 months. So we did counsel the patient about, the guarded visual prognosis of peeling at this stage and the kind of unclear visual return.
So Lucy,
Mm-hmm.
before we get started with the surgery part, is there an argument for not doing anything?
Is there an argument for not doing it? I think because this hole has been going on for a long time, and because it is so big, I think the chances of it self-closing is fairly low at this point. I think there's always the argument to not do surgery if the patient were like medically ill, if he had other like systemic comorbidities that would preclude having a safe surgery. But in this case, because he was symptomatic, he's someone who's fairly young with like binocular vision, I think there was an argument to go ahead and do it.
And then if you go back to the OCT, so maybe there's an RPE defect there, maybe not. There's certainly some hypertransmission, but it does seem to correspond almost directly with just where the hole is, and not on the outside toward the edges of the hole. So maybe it's just transmission, and maybe it's not an RPE defect. So something to consider.
Right. Okay, so our surgical plan here was to go ahead with a 25-gauge PPV, planning on using Brilliant Blue for staining IOM and kind of doing a combined IOM ERM peel. There wasn't a very clear ERM on the OCT. And then going forward with a pinch and peel technique, and also ending the case with a 20% SF6. And there were some other kind of more advanced techniques that we considered, but did not use in this case. And I'm curious as to our illustrious audience here, if you guys would have considered any of these kind of more advanced techniques for this this specific macular hole.
I think
some good
Peter
questions
Tang is
coming
there. Yeah.
Go ahead.
So C3F8 maybe. I've done it before. I usually don't for macular holes. If they're really big, I might do a long-acting gas bubble. Anyone else?
So typically not for a primary surgery, you know, unless it's like really big, they've got trauma, something else. I think often, you know, at least in my hands, just standard ILM peeling with SF6 works really well and has a very high closure rate. Kat had asked a question about cataract surgery or phaco at the same time, and I do tend to do combo phaco plus mac hole a lot of the time, just because there is some evidence of the holes reopening with subsequent cataract surgery. Anybody else?
If my view is good, I'll leave the cataract for later. I feel like if I've done a good ILM peel, I don't need to do it. But if there's a marginal view, then either stage it or do it at the same time. I tend to do very few at the same time. So a question back to you, Sumit, do you do your own phacos or do you combine with the anterior segment surgeon, and why or why not?
So mostly for billing, we just combine with the anterior segment surgeon, but I have done it myself before too. There's not one available.
I think that's
The
a
only
really good
reason-
question. Sorry, and Alex brings it up in the chat a little bit, but it really depends on sort of your practice patterns. You know, obviously as retina surgeons, we depend, you know, on referrals often from our cataract colleagues. So I think you just have to be a little cognizant of things. But sometimes with scheduling, it can be hard to align with someone if a comprehensive person sent them to you and you guys don't have the same OR day.
I have had the I have seen the IOL pop out of the bag when filling the eye with gas, when doing it at the same time. So it's not like the only type of vitrectomy with gas that you would do with the phaco. So it's, you know, I think, but if you can avoid it, I'm with Prithvi. If the view is pretty good, I would probably err on the side of just doing it at stage.
I would put a little Myocol in before I do my final gas exchange, just to try to keep that IOL back. But I don't have any other tricks to prevent what you're talking about, Loshan. Maybe the higher gas concentration could be the other problem too.
I was going to ask the Cole people who say they routinely do combo if they give their anterior segments colleagues any direction. Like when I have we don't have combo cases in terms of having a separate surgeon. So when we do the phaco combo, it's the fellow or the chief. And I tell them to do like a baby rexus. So to basically aim for the size of the optic or smaller, as opposed to like a nice big rexus that some of the other anterior segment surgeons who staff them may prefer. That's the only thing that I tell the trainee when they're doing that. I don't know if you guys do the same thing or you let them just do whatever they want and then you figure it out.
Smaller rexus, like some people mentioned in the chat.
I think it's also good to put in the ports first before the phaco is done.
Mhm.
I think that's really helpful to prevent sort of prolapse.
Awesome. Thanks everyone for all these really great discussion.
I tell them not to do an extra cap, but I'm good otherwise. Take it away, Lucy.
All right, let me find my video. Wait, can you guys all see the?
We see your in screen. Yep.
Yeah, I'm trying to figure out a way to get so I can still see you guys. Just like full screen this, I seem like I can't. I lose.
You don't need to see us, Lucy. Honestly,
Yeah.
we're not that exciting.
And you just see the disapproval on your face.
That's always
Prithvi,
there.
I'll
That's
send you a
constant.
picture of Prithvi. That's it.
Okay.
Like that's a constant look.
The tears are pouring down.
Here
All right,
at Cole, we're always smiling.
I frown a lot.
Okay, if you guys are okay with this amount of max.
Perfect.
Okay, cool. Okay, so here where I wrote down the speed so that we don't get confused. I don't get confused. This is a 10x, just putting in this spherotomies, going familiar behind the limbus. You can see phakic, and here's just showing clippets of our vitrectomy. And looking back on this, there's definitely a lot of things I could have done better. I could have made the light kind of further back, made it more diffuse. Should have illuminated the tip of my cutter kind of more consistently. But I won't belabor that for our peeling session. So here we're going in with brilliant blue, letting it stay for 2 minutes. And here you can see that there was this really interesting kind of petaloid pattern. And here's put on the macular lens, which I'll talk about. But it looks like centrally the brilliant blue didn't really sting as well as peripherally. And our interpretation was that there was probably an ERM, that where the brilliant blue didn't take as well. And
Lucy, what's your technique for injecting dye?
in technique for injecting dye.
You just use a syringe and soft tip, or what do you do?
Yeah, syringe. And then I've been trying to kind of self-inject instead of having an assistant inject on a syringe with varying success.
So syringe on a needle, syringe on short tubing. How do you do
Yeah,
it?
I think in this case we use a soft tip, if I remember correctly.
We don't use the connector tubing, Sumit. We tend to have just on the TB syringe the soft tip, and either self-inject or the assistant push. Do you have a little connector for stability?
I use I aspirate it with the retractor and reflux.
Valley,
That's
we
what I usually do.
a tubing connector, so the assistant injects.
Yeah. So it's the nice, I mean, what Sumit was mentioning is a nice technique, either using the retractor or using the soft tip to aspirate out of a cup or something. And then, yeah, and then you just reflux in, and then you can leave the thing in and then just aspirate out after 30 seconds or 60 seconds.
Okay, so here, starting the peel. So my goal was kind of to make a little rent, kind of going.
So I know it's early on, but choice of forceps.
Oh yeah, so
whatever you get handed.
Yeah, so whatever I handed. So here I was handed the ION forceps, and I think it's the one that I've had the most experience with my single digit number of peels. So I didn't see a need to kind of use another one. So here I was encouraged that I did get a little bit of something there, although it did seem like it wasn't really coming off in like a sheet or anything successfully. In retrospect, looking at this, I probably could have gone, I knew I wanted to go kind of temporal, but to avoid the bundle, but probably could have gone like a little bit closer to like to directly temporal to kind of go more in the watershed zone. So here I'm just made a little rent, and so far like no bleeding or anything yet. So just trying to enlarge it. And looking back at this video, I think there are definitely like places where I could have turned the forceps in a more ergonomic way to like align with the edges of the opening.
Don't worry about that little hemorrhage. But yeah, your choice of location to start. What's your comment on that? I know you said maybe you could start a little bit closer or a little bit.
Yeah, I guess close. Yeah, I probably would have, in retrospect, would have started a little closer to the to directly temporal of the fovea, just to like be closer to like the watershed zone. But I think it worked out in this case, but I probably would have started there if I were to do it again. But I think in this case, I also was just because, it's still kind of new to just putting on the lens and like getting focus. I think I just naturally went to where my hands like ergonomically wanted to go. So I think in that sense, I can say I sacrificed a little bit of like anatomical optimization for like, just comfort.
And you may find that starting a little bit more posterior will give you, that angle of your forceps means that you can't get as much of an actual pinch of the ILM. And even though, it's a little bit harder to see the grip when you're kind of coming at it head on, it may be, the angle maybe make it easier for you to grasp it.
Got it.
The other thing is, sorry, go ahead.
I was wondering, did you adjust intraocular pressure for the hemorrhage or?
Yeah, so I've seen it done where we can go to IOP 60. I think for this case, because they were fairly small and wasn't like, didn't really keep bleeding, we didn't worry about it so much in this case. But yeah, I mean, looking at the video, there were definitely parts where, you know, I could see a bit more whitening under my forceps than was ideal. And Dr. Doe was very, very helpful in like pointing out when that happened intraoperatively to kind of lighten up on the grip.
To the other faculty, when do you use like a flex loop or a tonneau scraper or something to start your edges versus first year fellows pinching and peeling? You have a set rule or?
Yeah, I'm a big pinch and peeler. That's what I primarily do when I'm on its own. But I think learning how to do pinch and peel is really hard as a first year. And I find that the flex loop is pretty like forgiving. I also use it as sort of my go-to if a patient has like a lot of like breathing movements, a lot of like excursions, that it really sort of makes it a little easier to get started, and then it's easier to grab. The hardest thing I felt like as a fellow when doing pinch and peel is when the ILM is still attached to the retina and you need to go down and grab it. And so anything you can do to make that like a little bit easier for yourself, I think sets you up for like more success earlier on while you're still working on those technical skills.
Yeah, so here we're getting to kind of the edge of where like that petaloid staining of Berlin blue, the ILM kind of merges with the part where it's not stained as well. So here we're expecting more of an ERM kind of directly overlying the hole. So as you can see here, like it starts kind of coming off in a bit of a bigger sheet.
There didn't seem to be that much ERM on the OCT.
Yeah, it's very weird. Yeah, so I know that when we looked at this video last time, oh shoot. Uh-oh. Is this, you guys still?
Yeah, you're still on.
Is it doing weird buffering?
It's just frozen. Just pause it for a couple seconds and then restart.
Okay.
Yeah. Yeah, I'll tell you for my when I have first years, I do like flex loop or a diamond dusted to get them started, especially just right at the edge of a blood vessel, just to give them a nice like a consistent edge. But and it is at some level still going down to it. And I know Peter hates the diamond dusted scraper. I love it. Used it a ton, so I'm just used to it, and it's something that I got very used to, and there's the force of it. But to each their own. I think there are so many different ways of doing this. So I think success, right? Lowest risk, highest reward for any of these for any of these cases. And I agree with Kat. If the patient's head's moving, I think using some sort of instrument makes a big difference. And a technique that I encourage all my fellows to do at some point in time is to try to peel just with a flexible loop or a diamond all the way around. If the view is bad, you know, in some of these cases, you can use just one of those instruments to essentially do almost like a pseudorhexis.
You know, the other way to think is Scott Walter has been presenting, and he comes to these rounds too, where he initiates with a pinch, or he initiates with a loop, has a flap, and uses a 27 gauge cutter on very low aspiration to guide the ILM rhexis around as well. So trying to minimize, you know, opening another forcep and another instrument. So different ways to do it.
So Lucy, I noticed you're kind of going, it seems like you're aiming to go arcade to arcade, or at least something close to it. And there's nothing wrong with that. I mean, I think I used to go arcade to arcade, or I'd go as wide as I could. I think that also speaks to how far away from the fovea you started. Was there any thought to, given the size of the hole, that maybe you're going to try and preserve some ILM for later in case it doesn't close?
I don't know if I thought about it that much interactively, actually. I think
her holes close 100% of the time, by the way.
No, but that's a great question. But I think back to our the previous comment about trying to initiate our rhexis, I think once we kind of curled it around it, I was almost like just trying to make it look symmetric, realizing we had a little bit more to peel kind of superiorly and kind of but I do think I think I probably could have made it a little smaller, and in retrospect probably could have started a little bit closer to the fovea. That's what you mean.
Or I guess that could be a question for other faculty as well. I mean, I certainly have been burned by holes not closing and wishing that maybe or trying to think ahead and maybe trying to preserve some ILM for later.
I see.
This gets to kind of like, next step. If it doesn't close, what's your move? Like, would it be, autologous ILM, or are we bringing in amniotic membrane at this point, or going back and roughing up the edges or using subretinal fluid? I think it's the array of techniques available.
That's a separate COBRA.
Yeah.
COBRA.
I'm closing back holes.
That not closing back holes. Don't give it away, Dr. Mruthyunjaya. We're going to be doing that later.
Sorry. Okay, fine.
Yeah, I do wanted to show this one thing here where when the ERM kind of came off the fovea, there was this some of this kind of yellow lutein pigmented tissue kind of came up with it, right? And there now you can see a little bit of that everting kind of from the hole. So I'd love to hear kind of everyone's comments on that. But here, what we're doing here is we went back in with a Tano scraper, and what we're trying to do here is just kind of repositing it back into the fovea. Which this part was really fun, getting this close to the fovea. That was this is what I came to retina to do. And here where it was just a vitrectomy afterwards to kind of clean off the little bits of floating membrane. Here was some endolaser. It was a little bit of a lattice with traction that we had noted intraop. Here, air fluid exchange, and filling the eye with gas and closing the sclerotomies.
How thorough of a peripheral vitrectomy do you do, Lucy, in these cases?
So in this case, we did some, but we didn't like go super close, and we didn't like depress, and we didn't do sort of torsion like all around. But we did we still did some shaving, but not like for an RD where we would do a very thorough shave.
Nice job.
Perfect. Do you have a follow-up on the patient? Did it close?
Oh yeah, let me show you the post-op. Yeah, so I was very encouraged to see that the whole closed on post-op day. Post-op week 1. You can see here that there was still some missing RPE, missing outer retinal layer. And it kind of got me thinking about sort of the yellow pigment that was everting from the from the hole, and like repositing it if we had done more repositing, if that would, I don't know. So these are things I kind of wonder after the case. But also what was, I think, encouraging was that the vision actually seemed to improve at post-op week 1, going from 2600 to p-pill to 2300. So that was encouraging.
That's a great result.
Very nice.
It's a good win. Good start.
Thanks.
Sunil, is there more peeling going on in Cleveland?
We got some more peeling. We're gonna move on to our next case, and we got a couple of great people who are going to talk to us about this. First, we're going to start with Eric Jung. Eric is one of our first-year fellows. Eric did his undergrad at UCLA. For all those who were Browns fans and got to see UCLA produce quarterbacks here at the Browns game, they produce better retina specialists than quarterbacks, is what we've concluded. And went undergrad at USC and was a resident at USC as well. And we have two fantastic mentors. Sumit Sharma is going to be primary, and Kat Talcott as well. I know we got a couple other Cole people who are going to probably chime in and criticize Eric. So that's the way we do it at Cole. Lots of love that's defined in many different ways. Take it away, Eric and Sumit.
Alrighty, thank you everyone for having me, and I'm sure you'll find a lot to criticize in this particular video here, so looking forward to it. Can everyone see my screen here?
Yep.
All right. Alrighty, so basically I'm going to be presenting a very similar case to Lucy, basically an ILM ERM peel with my first attempt at a pinch and peel technique, basically biting off more than I could chew. And preview, it was...
Is that your pet?
No, this is a graphic representation of me. You can look into my eyes there and see how overwhelmed I was there.
Very, very good. Awesome.
Yeah. All right, so our case is a 59-year-old male with basically central scotoma for a year, referred by our comprehensive colleagues. Past medical history consisted of obstructive sleep apnea. He had prior MI, hypertension, restless leg syndrome, and he did have a history of ocular trauma 30 years ago, but never sought any care for it. So, sort of unknown sequelae. on exam is visual acuity in the eye of concern was 20/80, and other than cataracts, mild nuclear sclerotic cataracts, and the full thickness macular hole in the left eye, exam was pretty unremarkable. There was no obvious PVD on exam. So here's the OCT. We see a large full thickness macular hole, and kind of similar to Lucy's case, we're already seeing some cystic changes, but there aren't, you know, it was chronic per history, but kind of unclear. We didn't have any prior OCTs to compare it to. The posterior hyaloid's not clearly visualized here, but we can see maybe the beginnings of a trace ERM there, especially on the lower slices. So our plan at this point was to do a combined.
Hey, Eric.
Yep.
Sorry, hold on. It's Alex here. I'm just going to stop you for a minute. Would anyone with that history of trauma, very remote history, would anyone have just said, traumatic macular hole, let's not fix this? Or would everyone give it a go?
I would give it a go.
It's been there a long time. I think that if it was closer to history, you could have maybe watched it or tried some NSAIDs or magic potion, and it could have gotten better. I think this has been there a little while.
And without any evidence on exam of any like RPE loss or choroidal rupture, I think probably worthwhile to give it a try.
Yeah,
The vision's pretty good.
yeah, I agree. The vision was pretty good, and it looked with all those cystic changes and without those more chronic traumatic signs, we decided to give it a go.
Although this hole looks a lot bigger than Lucy's hole, actually, even with the better vision.
It does.
We didn't measure it, but yeah, just basing it in comparison to the thickness of the retina is probably like a good maybe 600 or so.
Yeah, definitely over 450, but yeah, unfortunately in our get images view, we aren't able to measure it there.
Hey, Eric, there's a question whether there may be some lamellar proliferation on the edges there, and even though it's not a lamellar hole, does that impact how you want to proceed with this, or what you're going to do or not do?
Yeah, I actually didn't really discuss that preoperatively with Dr. Yoon. I do see sort of those ruffled edges.
Not there, more at the superior
bottom.
edge.
At the
Not
top.
there. So on the top of
Okay,
that, right there.
there,
Yeah,
right
that's
there,
right there.
It's not a lot.
It really didn't change my particular thought into the approach. It seems pretty minimal. Why would you have done something different? Would you have planned for this differently with the?
I just think you have to be aware that the edges of the membrane, once you start getting up to that, can be really, really sticky, and you don't want to go crazy trying to lift it off of there. Sometimes you just think about trimming it at the edge instead of anything more, but just be aware that it might be stickier than normal.
Yeah, especially that lower left image, it really looks like there's membrane invested into the retina. So
absolutely. So as you come up to the hole, if it's really pulling on edges, then just be really careful and trim it down. Don't try to get it off the edge completely.
Kat talked about it doesn't make a difference really unless you're thinking about doing a flat. Kat, do you want to expand on that?
Yeah, I was just thinking.
Agreed with you.
Yeah, I was just thinking through that and going through that in my head, because I agree with Sumit. You want to sort of be careful about how much traction you're pulling on the edges of the hole. But if it's a large chronic sort of hole, it might not be a bad idea to just kind of plan on doing a little bit of a flap where you have kind of a little bit of ILM stuck around the edges and not worrying about it. So it actually might make it a little bit easier in some ways.
I think that we'll get to the video. I think the issue for me is if it's a pucker lamellar hole type scenario, then I think all that consideration comes into place. You can say this is a chronic, pretty good sized macular hole. Even if you kind of pull on something and it roughs up the edges, that just may help for closure, because I think the anatomic closure is probably what you're going for here. But it's all good points.
I totally agree with that. And that's kind of how I was thinking going in, is if this was an ERM, maybe I would have been a little more careful. But with the Mac hole, I thought it would probably come up easily, and if anything, it could rough up the edges, like Priti said.
So Eric, we're throwing caution to the wind. Show us what you did.
Alrighty. So our surgical plan was basically there was a mild cataract, so as kind of discussed in the previous case, we elected to do a combined phaco along with vitrectomy, ICG, and peel, and then also S of 6 for tamponade. So I'll go to the video here. So basically, we're gonna skip forward through. We basically just confirmed that there actually indeed was a PVD, eyelid was not down. Did a vitrectomy, and then here we're using ICG. Kind of the first point that I realized when looking back and also talking with Dr. Yoon at the end of the case was to be really mindful of how I'm injecting the ICG, making sure it doesn't hit the fovea, especially in a MAC hole case, to prevent any theoretical concerns of the ICG toxicity. Here we're trying to, we can see, let me pause.
So can I pause it for a second? So we glossed over this a little bit, but in the last case, this is good. When you're pinching and peeling, what did you learn from this in terms of what you should do versus what, I mean, it says pinch and peel, but it's more like a pinch release and then take a look again and then peel.
Absolutely.
Right?
Absolutely. Yeah. And this was actually something that Dr. Yoon was teaching me was just like you were saying, even though it's called pinch and peel, you definitely don't want to have a deep grab, start peeling, and then actually find out too late that you have retina. So what I'm trying to do here at first is trying to get the right depth, doing a couple pinches and then letting go to confirm that it was really ILM that I was grabbing and nothing under. But you can see I'm kind of being timid with it in some ways, and then also too aggressive in others when you're seeing the retinal whitening. So I think kind of titrating the right amount of depth was pretty difficult to start here. But here, there I am trying to kind of pinch and then release, and you can see I've made a little bit of an opening. But what I also found that was a lot more difficult with this was even after you've created a little bit of an edge with a pinch and peel technique, it's nowhere near the size of, a nice flex loop edge or, one of another instrument. So just grabbing that tiny little edge to propagate it was a lot more for me too. And then here we're getting to kind of a point, I'm getting very frustrated here, kind of having a hard time grabbing that edge. And here I do the unforgivable mistake.
It's a video. It's a video. Don't touch it, please.
Basically hitting that retina there. This is kind of, we're all taught that we are, the retina is a bowl, the macula is a bowl. And in this particular instance, I was not, very respectful of that. You can see I'm actually starting pretty level with the fovea in terms of how superior versus inferior I am. So I'm pretty lateral with the fovea. And I think because I was just used to being more inferior at that moment, kind of that natural movement, having a little more slack to go down. But yeah, so don't do that.
Hey, Eric, can you show it again, if you don't mind?
Yeah.
I just think it's a really good point, and I thank you for showing it. It's not easy to show this, and I just like all the faculty here to kind of chime in a little bit. Eric, you made some nice pointers here of like how to look out for it. So I'm just curious, faculty, what are the pointers you can point out to Eric here, and maybe to our colleagues, the things to look out for?
So I see this all the time. It's a early peelers, I think, tend to concentrate so much on exactly where they're where they are, but not where they're going, and forget that the eye is curved. I think you really have to kind of think about where you're going and not just look at where you are.
I think that's a really good point, Alex. And then I think part of it's like the transition from being sort of a resident where you're doing cataract surgery all day to doing retina surgery. I think that, we're all used from sort of doing like a rhexis for cataract surgery of just trying to stay nice and flat. And you have to be careful about doing that when you're peeling ILM here, because you can run into the side of the retina because it is curved. And I think most of us, like at the beginning, would rather have you be farther away from the retina, even if it's a little less efficient, than sort of be close. But it is, I think, very natural for people to do that as they're learning retina surgery and peeling.
Sumit, besides yelling at the fellow when it happens, anything else you found?
I mean, so it depends if they're bleeding, going up on the pressure. It just depends on what you're seeing. But I think, especially with early peelers, I'm often saying, go ahead and watch where you're going. What you need to come up with your hand as you start to lift here, because it's something you see, as Alex mentioned, very frequently when you're first peeling. And if it's way out, you could even start to, if it's bleeding, you can sometimes just directly manually tamponade it with the tips of the forceps. But there's a number of ways you can approach that. Usually just going up on the pressure is enough.
Yeah, when this happens to me with my fellows, I think, I haven't communicated it to them. I think this is something that, it's hard for them to know. And I always have like a 2-second count. Like if they're peeling, I always say to them, watch where you're going after like a second or two, because if they're moving too much, I think, they just get lost. And it's just, it's normal. We were all here. We all have done this. Every single person who has peeled has done something like this. So, don't feel bad about it, Eric. I blame Alex.
I'm gonna so thanks for sharing, because it's really important for us to see this. A couple of tips I'll say is that, especially early on, don't panic. I think what will happen is that sometimes you'll hit the retina and you do the opposite of what you did, which is you pulled away, you kind of retraced your steps and got out of it. Sometimes once that happens, you're frozen and you just keep going, and then you start gouging deeper and deeper, and then terrible things happen. So once it happens, like, and this comes like with that spatial awareness of like, being able to stop on a dime. So, and sometimes you don't even know it's happening, especially to the light. So the light's like touching, your peel is going great, and you're like, what's wrong? The peel is great, and your tendon is like screaming in the background. It's because they're seeing the light hitting. So when something like that happens and you hear like the attendings, saying, stop, don't move, like literally, like don't keep going, like stop. So you did the right thing. And so remember, the light could be hitting, the forcep could be hitting. And then also, as soon as you see blood, like don't wish that all that just goes away. Get that bottle up, get control of the situation. It'll buy you a few seconds or a minute or two to just kind of like, recenter yourself, and then you go from there. And one of the other things to keep in mind is like, did that happen because maybe you're in a funny position, or your hands were like too tight or too clenched? I think you can pull out, take a second, shake it off a little bit, and then get back in.
I think that's one thing we haven't talked about for either of these cases for our first is, what do you do outside the scope to set them up so they're steady? Like, is everyone using a wrist rest? You roll up a towel and rest it under their wrist. Like, are you telling them to like loosen up their upper arm, because sometimes they're all tense and then it translates into their finger, their hand? Like, those are all things to think about before you get into the eye, is setting yourself up for success. And it's not just the pinch and peel or whatever, but the rest of your body needs to be comfortable and relaxed.
I think that's a great point. And also don't forget about port position. I think in these peels, it's important, and I like being a little more horizontal with the with your main hand port for these peels. I think it gives you a more natural position if you're closer to the 3 and 9 o'clock.
I tell every fellow, relax your shoulders. Just relax. Relax your shoulders. Give me a shoulder shrug. Just relax your shoulders. And then for those who's, when the wrist rest isn't set correctly, which it never is for first years, don't, if you feel like you're tense, to put a towel on. And I tend to notice those who just, sometimes I set the wrist rest, and my fellows who have different hand size like it at a different spot. So I think it's important for the fellow to set the wrist rest to make sure it's in the right spot for them.
Carolyn sets the tone with important points about preparation before you get into the eye. I think that's we're hearing that now.
Go for it, man.
I have to commend Dr. Yoon here at this point, because number one, he stayed very calm and still just a very calming presence, and also then had the idea of, hey, why not switch back to something you feel more comfortable with at this point, and that was flex loop. So I think another thing to do is also, use a security blanket if you have one, and kind of go back to things that might feel more familiar. So here we are, going back to the flex loop and just trying to develop more of an edge, something that's just more easily grabbed. And then we do see a good amount of negative staining there, indicative of the ERM that's closer to the fovea there. And you can see that as we try to extend the flap, some of it does start kind of shearing closer to the fovea there. So trying to release and then trying to get more
so I think, Eric, you're doing some great things here, and that you're moving slower. How you've slowed down compared to before. And I think that's actually great, because when you go really quick, you're more likely to shear something off, whereas taking your time and really moving slowly, especially when you're starting, is very helpful in these cases.
Mm-hmm.
And I think that's a fantastic point. I think every time we watch these videos, they're always sped up. So, trainees will have in their mind, wow, this peel should only take a minute. and we forget the actual peel itself can take a little longer than that. It's important to be very deliberate with your movements.
And Dr. Yoon, I believe it's a cyclodialysis spatula that you use, but you'll see occasionally here Dr. Yoon kind of directing me in terms of guiding me where to go, and that also is such a great thing to have when you're a beginning peeler, to kind of tell you, hey, maybe this edge here is something that might be grabbed easier. So it's a little bit harder to see, but there is kind of that ERM going in. Unfortunately, I didn't have all that preoperative consideration taking place in terms of being more gentle with the ERM peel. You can see I am trying to kind of take it all the way off around the full circumference of the hole there. And that's kind of the last bit right there. And then what we did next was to do a restain with ICG. So at this point, just to make sure that any residual ILM we're able to visualize. And then here we're just seeing a little bit and kind of getting it out a little bit further away.
Just trying to ensure full toxicity when you can. I understand. That's good.
Exactly. The second time around, I was a little bit more mindful of trying to shoot away from it. But and actually, that brings up a good point too. Rewatching this video, I realized my light pipe was so darn close to the macula the entire time. And just another thing to be mindful of, especially with, if you're trying to minimize light toxicity and you have ICG in the eye and such, just kind of being mindful of how close the light pipe is. Also, of course, to make sure you're not touching the retina with it. And we're doing our fluid exchange. And as I mentioned previously, we're going to be filling up the eye with SF6, 20%.
The double staining, I think, is something I didn't do so much in training, but I find it very helpful these days, especially with fellows, to be able to feel good about getting everything out. I think it's a good thing.
Mm-hmm. Yeah, and this was also the first time I used, or this day was the first day that I used the Zeiss Resight green lens, the 60 diopter lens. And actually, it's something that Dr. Yoon likes to use, and I found it to be really nice, especially just because I was already used to the way to move the scope, and it felt a little bit more natural. And the little bit that I lost in terms of stereopsis, I thought I gained with just a larger field of view. But happy to hear y'all's thoughts on whether you like that lens or a flat lens only, folks.
Whatever works.
Yeah, I agree with that. But I also feel like in my hands, I agree with Kat that I feel like it's just not forgiving in terms of when you're kind of moving things around.
So I find if you lift the scope a little compared to where it was with the yellow lens, that it gets a little more forgiving. You keep stereopsis better, and it's much easier to use. And it's not much. You just have to come up a little bit higher, and it's so much more forgiving once you do that.
I think the green lens, especially when if you're not set with your yellow, you're not you haven't become parfocal with your yellow. When you flip to green, you're not in it. So you have to start all over again and just make sure you're set. So yeah, I mean, I like the green a lot. I'm a huge fan. But so some people like the flat lens, and the flat lenses we have now are incredible. Like there's some incredible lenses. So whatever works, whatever
you should try both or all, right? When you're a fellow, so you're not just fixed on one, because you don't know what you're going to get when you go to your next place of operating. So 2 really good examples of macular pinch and peel surgery.
What month is it again? What month is it? It's October, man, and that's pretty good.
They're child prodigies. Child prodigies.
And for those who are fellows who are watching who haven't done their first peel, you are not behind. This is not a sign that you're in a worse fellowship or a better fellowship by when you peel. It's all about getting there at the end. So like this is just comfort level with attendings, and every training program has their own gestalt with it. So just be aware this is wherever stage you're at, you're gonna get there. Okay, so you just got to kind of keep grinding. And I will take you back in the old days of retina, no fellow peeled. You waited until you were an attending. Those are some of the great ones that you know of who are out there. They peeled on their first peel was when they were an attending. So I promise you'll get there. All right, I think we're sticking with Cole, right? We're gonna do another one on this side. I think
different diseases, same peeling. We're just peeling away today.
Yes, I love peel. We're going to talk about it in a different way. Leanne Clevenger, our second-year fellow, is going to take it from here. Leanne did undergrad at Wake Forest, medical school at Baylor, was our chief resident, now our fellow. I will let Leanne share her good news of where she's going next.
I'm employed. I think I signed to go to the University of Kentucky, so I'll be headed there next year. Woohoo!
Fantastic. Welcome to the dark side of academics. We love that you're joining us.
Awesome. Well, thank you. So I have a little bit of a different interpretation on peeling. So I do have a little bit of macular peeling, but my case has more PVR focus. So I'll see if I can switch that over now.
Still counts. Still peeling.
Can you all see the
Yep.
slides? Cool. Okay. So my patient, she's 72. She has a history of a recurrent retinal detachment with PVR in her left eye. She's had a buccal vitrectomy initially. At that time, she actually already had early PVR and then redetached. At the same time, an epiretinal membrane peel was planned. They did the retinal detachment repair at the same time with another vitrectomy and phaco. And then she had another recurrent detachment the same year, another vitrectomy, retinectomy. She had silicone oil placed, and unfortunately, she had silicone oil removed after she was stable for about a year. And then I'll show you about 2 weeks after she had the oil removed, she comes in with hazy vision. She's count fingers and her eye pressure is 11. So you can see she now has a recurrent detachment, possibly early star folds in the kind of temporal macula extending peripherally, and then she has a looks like almost a 270-degree retinectomy already, but kind of nearly completely detached here, and no obvious breaks, but presumed one at the edge of the prior retinectomy. So first thing we do is put kinolog in, looking for any leftover vitreous. First, could initially just go to the more peripheral kind of PVR, and then wanted to assess, did this extend over the macula? So looking with our intraop OCT, returning kind of back with the max scripts, trying to get as much as the PVR off as we could, and looking inferiorly, she did have this band that extended from the periphery towards the nerve, segmented this, and we're able to kind of peel that away.
Professor Leanne, I have a question.
Yes.
Do you, what about using steroid or something? Like, do you feel like that's helpful in this situation to be able to identify membranes, or can you just see it all without any assistance?
I don't know if in this case they're particularly helpful, but I have seen where they have been. I think For here, the configuration of the retina was kind of more the biggest clue, kind of being able to see kind of where that star fold was. But kind of for some maybe more early PVR where it's kind of more sheet-like in appearance, the Kinalog can definitely help highlight that for you.
So,
I
so we put it
completely
in
agree.
here, right? And it didn't really
It
catch
didn't do
anything.
much.
Yeah. And so what about here? So you're peeling anterior to posterior. What do you worry about when you do that? What are things you got to be aware about?
Yeah, so I'm worried about too much traction, either peripherally or at the nerve, but especially since we're pulling from posterior to anterior, we're worrying about the edge of this retina kind of coming up. So we gently kind of teased it before we kind of peeled it away, just to make sure there was not really any specifically strong point of adhesion that would rip or cause a break or a tear. Sometimes there can even be some already hiding underneath that, especially kind of with this band of PVR extending. So I think we looked really carefully to make sure there was nothing before we started peeling away.
Okay. Leanne, were you 100% sure this was going to retinectomy? Like, was that the pre-surgical plan for you, or you were going to give it a shot to see if it could flatten?
We were pretty confident this is going to be retinectomy just based on how stiff the retina was, and that she had already had a partial retinectomy. We kind of felt like that was the direction she was headed. Would anybody have gone have done otherwise?
I think we were also worried about some subretinal bands, and we were worried about how that inferior edge just didn't look clean to me. Like I was really worried about leaving that retinectomy inferiorly, right? So I tend to never leave it inferior like that. I like to get it away from the 8 and 4 o'clock kind of out, so that it's not going to go there. But you can put it down. My thought here was that she'd had multiple other surgeries elsewhere, and she's now coming for getting this fixed, and let's get it fixed, and let's not leave any inferior retina where it's going to just redetach again.
So we get that sheet off and kind of now focusing more on our macular peeling. So she'd had an ERM peel with ILM peeling reportedly before. So we could see that there was an area kind of around where the fovea was that had been peeled, but wanted to extend this further and even take it more temporally to try and see if any of that PVR would kind of come with it. I think.
Professor, let's help the crowd here. So are you using the green to make sure you have ILM removed, so you're reducing future proliferation, or are you using this as a way to ensure all your pre-retinal membranes are off? And how are you distinguishing that in this location?
I think it's a little bit of both. She had already had like the fovea peeled, so I guess in some sense her risk of recurrent ERM, kind of PVR ERM in that area is less. But I think for us, starting kind of towards the temporal edge of what had already been peeled and peeling it more temporally towards the area of PVR was more trying to get up the kind of sheet of PVR that we saw kind of extending more temporally here. We'll take it back nasally though too, don't worry.
Yeah, because I think that's two different reasons for doing it. Probably the same end goal, but one could be trying to, and as people have been talking about on the chat, getting a wide ILM peel so that if there's reformation of PVR, maybe you avoid like macular puckering, preventing like a star fold in the macula because you've gotten rid of some of that scaffold. But again, talk to us about some of the challenges of peeling in detached retina here, trying to get ILM off. That can be a little harrowing as well.
Yeah. So how different does a pinch and peel feel when it's detached?
Very, and it's very different for this case than some other cases I've done that were detached, because she was a little bit more stiff. So I think I had a little bit more tension to actually kind of grab the edge of the ILM and pull, which was nicer actually than some of the more rhegmatogenous kind of detachments, which are a little bit more bullous, are a little bit more challenging to kind of read the tension on the retina. There's a little bit more, I think, more feedback. If anything, things are pulling in lots of different directions and not very forgiving. And for her, with that being there already, that was a little bit more forgiving in that sense.
So Leanne, was there any thought at this point, because now you're starting to peel pretty far out temporally there. Was there any thought to switching hands and trying to peel this with the left hand to get a better angle on it?
I think we do. I think we switch hands here pretty soon, actually. Yeah, it's a great point. Because we do reach kind of the end of the green lens and want to kind of bring it back, switch back to the yellow here. And then as we kind of notice the PVR start to come off, we realize that it's extending more temporally. And like you said, Alex, that left hand was going to do a better job for us. So we'll switch back here in a minute.
Be clear, we didn't do anything. This was all you. It was not me at all.
So at the edge here, a little bit nervous about, too much tension kind of right at the edge of the retinectomy, even if we are planning on refreshing it later, it was kind of our goal to kind of keep it intact for now. And so using kind of the light pipe to counterbalance that. And I think at this point, I return back to the more macular peel to kind of more of a, preventative kind of widening of the ILM peel that had already been done and switching back and forth between left and right hands just to kind of get the right angle.
What about peeling under perfluorocarbon?
I've not done it. I've seen it done. It looks nice, but I feel like to me, I like being able to see the kind of the edge of my flap and have something else to grab onto. I'm not sure if anybody prefers that or is more experienced could weigh in.
I think sometimes it can help, but sometimes it can make it more challenging because that flap just folds right back down and you're fighting the PFO sometimes as you're doing it. It just depends on the case. She was stiff enough that I didn't think it would make a difference. But sometimes when they're really bullous and the retina is just flying all over the place, then it can be helpful.
I totally agree. In this case, maybe that temporal flap, you did it beautifully, but the temporal flap propagation may have been assisted by some posterior PFO even for a little bit of time, just to give that third hand weight on the, in the peripapillary central foveal region. Then you could have been a little bit, you could have been as aggressive as you were, but maybe with a little bit more posterior stabilization, take that out and then finish your peel. It's a little bit of back and forth, but if you're having trouble kind of getting it lifted off that detached retina, it's another tool.
If you do that, how much PFO are you adding? Is it just like macular
enough
coverage?
Just enough, just
the right amount.
Okay.
Perfect amount. Yeah, no, just macular coverage. It may be an inconsequential smaller bubble, but it could be enough just to weight things down a little bit so that you're not having undue traction.
I think to someone's point they made earlier, this is sped up, so I've spent a lot of time just kind of slowly teasing it away. But at this point, we're moving to freshening up my retinectomy here, diathermizing, bringing it around, and really trying to get the anterior retina. Realize that I have another band to peel, so I was excited about that. Turn back to my max grips and using my light pipe to kind of spaghetti it out, and took a couple of tries, but it was pretty satisfying.
Can you tell us what you mean by spaghetti it out? What did you do there?
You're using your light pipe kind of as a fulcrum to prevent kind of more of the you don't want the pulling to be pulling straight anterior to posterior and kind of more tangential force with your light pipe. At this point, I realized, there's a lot of anterior loop and anterior retina here, and the visualization becomes challenging. And we do kind of realize there is a lot of anterior pathology I'd like to get rid of, since she's already had so much PVR and we know she's a PVR risk. So we did something I'd never done before, which was kind of switch our infusion and change the illumination to better visualize it, which was really helpful for this area.
Yeah, I think that really helped because we were struggling to get that material, and there was a big anterior loop band just coming around right to that area, and it was right underneath the light, and we couldn't see it. So switching is not something I do often, but it is something that you can do. Just don't forget that it's an option.
When do you decide to take the IOL out in these recurrent RD PVR cases that are pseudophakic?
I think if there's a big sheet, some of these PVR cases, I feel like you can already see that the lens is kind of becoming encased. And if you feel like you can't get enough visualization to dissect it off, then I think that might be a good option for her. We feel like we got pretty good visualization of that anterior pathology without IOL removal to do it.
Yeah,
I
I personally only had to do it once. Oh, go ahead, Samir.
I was gonna say, I find it that we do it less and less just because of the wide field systems that we've had, but I still, it's like a once, like every couple of years that I do it. You know, it's just the anterior loop is so fibrosed to the capsule that you end up taking it. And Dean's talked about this forever, about like in these recurrent ones, maybe doing it sooner than we probably realize, just to prevent just to reduce the risk of anterior loop. I don't think you can prevent it, but maybe you can reduce some of the risk of it.
Carolyn, would you have taken the lens in this case?
I don't remember the history slide, which number of vitrectomy this is, but I would consider, and it's not for access to the anterior loop, but it's more to remove the IOL and the capsule as scaffold for more PVR in the future. And then, put oil in or whatever I'm deciding to put in. And if she or he decides to stay attached, there's no more PVR, then we can always put a secondary lens depending on visual potential.
Or a contact lens works great.
Exactly.
I feel like that decision sometimes happens, that consideration happens too late in cases. And then you're like, I'm just gonna, let's see what happens, right? But when in your heart, you're like, I should have taken the lens. But then at that point, big wound, the view, like all that's there. So I think if you believe in that, I think that should be an earlier part of the case if you can plan it. Otherwise, it just gets a little messy too, and then we tend to leave more lenses in than we probably should.
Yeah, I mean, patients with their like hypotenuse in the clinic, those are the ones where I leave, like for sure you're out.
Yes, agreed.
Normal pressure, and I can see like the peripheral star fold and some posterior PVR. Those, I think I would have probably done the exact same surgical plan that you guys did here, but it was more a question to think about for other PVR detachments that come through your door.
The re-op, not on this one, but on a similar case, I think would require that lens coming, mainly because you also already saw a lot of anterior PVR in this case to begin with. It's just going to be floating around in there.
Yeah, but I totally agree, Prithvi. It's the sort of thing where you're really better off with your pre-planning, thinking about doing that.
I think hypotony is really the only time I really consider it now, unless I see a lot of pathology kind of encasing the lens. And the other one is if the lens is more shifting further posterior, that's when you've got anterior loop pulling everything back. And if I see that, that's the other time I'll consider doing it.
How much methotrexate did you put in the infusion, Leanne?
No, but she got some at the end, don't worry. We did methotrexate 0.4 and 0.1. And I think she got a series as well as STK, but she got a series post-operatively, which I'll show you, of the methotrexate. And this is her at post-op month 2. She's 2150. Her pressure is holding, and she's almost completed her methotrexate series.
Falling.
Yeah. What's everyone doing for their methotrexate series now? I've kind of been doing the Q2 weeks, but my N is very, very small.
I'm about Q2 weeks. We use a concentrated volume, so 400 and 0.05. So less volume goes in, less reflux, and the surface seems to do okay.
Yeah, I just get 0.07.
Yeah, and I just keep trying. I keep going to 2 weeks and then extending it a little bit, 3, and then I try to finish it within about 2 to 3 months if I can. But if it's looking okay, then I stop.
200 micrograms every 2 weeks PRN. I'm still not convinced of this. I think it early makes more sense. I'm not sure the benefit later on, and that toxicity, the AC is still something.
I think early makes sense. If I saw like blood and it's one of these recurrent cases, retinectomy edge, whereas before, as you remember, Sunil, like we'd go back the next day if there was like any blood at the edge. I can't nor do I do that, but I think those are ones that I'd be thinking about it, and I've seen again. I don't have
and I think data. The question to me is, when the blood goes away, does it mean you stop? Yeah, I mean, it's a great question, and we're not going to get the answer right anytime soon until you do a much bigger and other study, which I'm not sure is going to happen now.
There you go.
Nice job. Back to you guys.
Well done. So, because peeling doesn't stop in in PVR alone, we go to some diabetic disease, and Karen Wei is our senior fellow here at Stanford, one of our senior fellows, and she'll be presenting a case of really bad diabetes, mentored by Dr. Carolyn Pan, who eats this for breakfast. Oh, nice.
Does this look right? Did I do it right?
That looks awesome.
Is it like do I have the whole screen showing?
Yes, we see your slides.
Okay. So these are my COBRA rounds, and thank you to Dr. Pan for being our TRD queen. This is a 49-year-old male. He's had poor vision for at least 8 months. He's never been to an eye doctor. He has PDROU. He's coming in hand motion in both eyes, and his hemoglobins have been okay as of recently. Here, I kind of wanted to ask the audience what they think they would do in this case. This is the Optos photos of his right and left eye, and their hand motion in both eyes. Hello?
We are stunned in silence.
Okay.
Which is the eye that most recently lost vision?
He has no idea.
I mean, I would give Avastin before trying to go into the right eye. The left eye looks pretty chronic and fibrotic already. But I would probably still give in Avastin before going in. I think the right eye looks more salvageable, so I would probably do that eye first.
Is the
Yeah,
left eye
OCT or
inoperable,
FA?
Alex?
I'm sorry?
Is the left eye inoperable? Because that's one of the questions that you could ask, right? Like, really bad vision, chronic, this doesn't look good. Do you give it a chance, or do you just say, we're going to keep it comfortable and do some PRP or Avastin?
I hate to tell a patient, we're just going to give up, but I think given a choice here, I would probably do the right eye first and before thinking about the left eye.
But OCT or FA, just look at how the perfusion is.
You said
I'm going to guess bad.
So I think Alex and I think the same way. When I met this guy, he had very poor history and did not know when he lost vision in either eye, but he said more than 6 months, maybe a year. We settled on 8 months. That was our average, we agreed on that. And then I talked to him about, which eye he wanted to work on first. He didn't care. He says, whatever you want, doctor. He has really poor social support. So he had been in and out of the ER a bunch of times with like high blood pressure and like didn't get his meds and then went back. And so my plan was, I thought the right eye was more salvageable. And I said, if we do the right eye and by some miracle you get better, then maybe we'll consider working on the left eye. But he's 47, 48. He's
49. He's pretty young though.
He's young. And so, I felt like we had to try something. We couldn't leave him like this with both eyes.
Yeah. So Dr. Pan was the one who had seen him previously and, discussed the very limited visual prognosis. We started with Avastin in both eyes and tried to get some PRP in the right eye. Asked him to come back in a month, but he showed up 4 months later. And you can see at this time we have some decent PRP in the right eye. And at this point, we decided to go for the right eye first for surgery. And we had planned for vitrectomy, membrane peel, discussed the possible need for retinectomy, laser, and probably oil for him. So we'll go for a video. Here we're separating the anterior posterior traction, trying to kind of separate out the posterior hyaloid as much as possible and make sure we're released. Put in some catalog. And then here we switch over to the macular lens and kind of go down to where we see the optic nerve, gently trying to lift up really, really carefully here. I know it's a little washed out. I tried to reduce the contrast, but gently pulling up
very slowly. And then we are intermittently switching between using the ILM forceps and the cutter here to create different planes as we kind of see different openings, and also switching hands a lot here. One hand having the light pipe, the other hand having either ILM forceps or the cutter.
When do you think of a chandelier?
I think in this case, we felt that using the ILM forceps, we're able to create good enough planes. But, I think certainly if we felt like, we're putting a lot of tension and we're not having enough counter traction, I think that would be a time to switch over to chandelier.
Sunil Eddy asks, is this an Emory throwback to Visco dissect?
Yeah, I mean, I think in these, anything you want to use, I think these are tools. What do you have in your toolbox? Where do you want to start? I put it in the chat. Like, you're just going to spend so long in this eye sometimes that just making sure the other things are happening in the background, blood pressure control, like what's happening with this patient. Unfortunately, I've had sick eyes like this from sick patients turn into ICU admits, one death. These are sick people. And so to me, it's whatever makes you efficient to give you the best chance. And then you can do a beautiful surgery and have a pale nerve because there's been no perfusion. So I don't know. I think visco dissection works great. I love it. But if you're not used to it, chandelier and go for it. I mean, I think those are great options too.
So I used to do these, modified en bloc. It looks like that fibrotic membrane might just come off the nerve and then everything might pop off. But I've more recently switched more to just going anterior posterior and actually even just trimming it all the way down towards the nerve and leaving it alone, because I find that there's so much bleeding in these cases posteriorly that if I start there first, it kills the case.
When
And then
Nico,
you have to up the pressure and then the nerve goes.
how do you avoid like running into like a blind pocket of the sciatic vitreous? So the reason like I start the nerve is because I know for sure your hyaloid, and then I can dissect and segment and then deal with each areas of traction. But when I come anterior posterior, there's always there's a sheet of hyaloid that's stuck peripherally still. And so I run into these blind pockets where then it doesn't help me peel the posterior stuff.
Yeah, so usually when I come anterior to posterior, it does come up against either that plaque or at the arcade, there's just fibrosis there, and it looks like it just stops. But then oftentimes you will, when you switch to your green lens or a drop-on lens in these cases, you'll find that on the macula side of that, there's actually a sheet of hyaloid that you can see. Sometimes you need a little bit of stain. And I actually think ICG can stain hyaloid in these cases fairly well. And you will often be able to find like a little separation in that plaque, and be able to even take a cutter and start kind of cutting through the plaque. And once you can do that, then once you're through from the posterior to anterior side, then you got the hyaloid, and you've caught the sciatic area, and you can just go from there.
So here again, like we started at the nerve, we're carefully kind of peeling away. And I know Dr. Pan kind of always uses the analogy like wrapping paper, just kind of seeing the areas that are giving as you're gently kind of pulling up. But I think, doing this process, this is obviously sped up. This took us a very long time, but Dr. Pan was amazing at kind of instructing which planes to try gently pulling up. And then when we felt like we were pulling on the retina too much in one way, moving over to a different area and kind of separating and making space. One thing is that, clearly throughout this case, we were fighting constant bleeding. We did pre-op Avastin, this gentleman, which I think definitely helped, and I'm so grateful that we did. But even still during the case, we're constantly fighting blood as well. And here we're switched back to the resite as we got a little more peripheral with our peeling. And here we're kind of shaving down this fibrotic plaque here.
My favorite cases are when I can't really recognize any anatomy. I don't know where the nerve is. I don't know where the retina is. These are my favorite.
Karen, sometimes we're in the midst of these like long, peeling cases, and you're being very delicate at first. Did you get to a point here where you're just like, I've got to go for this? Like, I know I'm going to make a break. Something's going to happen, but I've just got to get it off. Did that happen? And did you resist it? Did you go for it?
Yeah, so I think especially at the nerve, we always start out really slow, and then eventually you're like carefully trying to like peel and separate out this plaque. But I agree. I think there's often a point where you do feel a little frustrated, and and if you create a break, it's not the end of the world. Here we actually will encounter a break quite soon. But I think there's a balance, especially as you're starting to fight the cornea and hemorrhage, that you need to move things along.
Yeah, I definitely will sometimes just go for it, and probably sometimes too soon. But I think Karen, you are doing a fantastic job, and I think one point that you mentioned earlier that I think is really good to emphasize is that the principle of low-hanging fruit. You kind of go for stuff that's there, and then if it gets hard, you can always move on and go to something else that looks a little bit easier, and then come back to it. But people sometimes get really caught up in trying to do the thing that they started doing.
Yeah, it definitely helps that there's, so many different areas with this fibrotic plaque. We're kind of moving around trying to carefully peel off different areas, and we can see that we have a small break over here. But we're starting to feel a little happier about the amount that we've been able to pull up the hyaloid here. At least got it off posteriorly. But I feel like for these diabetic patients, sometimes it can be so tough to kind of gently separate and pull off this hyaloid. We put down a little perfluorocarbon to give us some extra stabilization. And here we're kind of pulling up as much as we can. We kind of feel like we've reached the extent of how much we can safely pull up the hyaloid here, and decide to move forward with a retinectomy.
Sumit, are you putting buckles on diabetics with inferior detachment?
Not typically. Are you?
Not typically.
So what's your exclusion? When would you, I guess, is the big question, right?
If there's not like, intrinsic stiffening, if there's a lot of anterior disease, maybe I didn't want to make a retinectomy. It's just a thought. I think that's also now in a diabetic, like an afterthought, like taking the lens out, at the end of the case. It would be something I could or should have done earlier.
Yeah.
In the case at the start, but I
Yeah,
tend not to think of it till later.
It's often what I'm like, oh, it would have been nice if we put a buckle on, but
Yeah.
it's at this point that I'm thinking about that, and now it's too late often.
Yes, exactly.
Creating our inferior retinectomy. It's more like 240 degrees here. And then at this point here, we saw that there's also some subretinal bands. We didn't need to spaghetti it out completely, but we're using max grip forceps to gently kind of pull these bands out, which is probably the most satisfying part of the case.
A lot of subretinal bands going around here.
Hey, we said peeling. Didn't say it have to be on top of the retina.
Yeah, that's right.
Pretty large.
Oh, that's nice.
And then there's
Yeah,
another as well.
I think I would have used a bigger forceps, like something with a. I don't know, it looks
that
like
looks
you're
like an
using.
ILM.
Yeah.
What would
I don't
you
know which
use?
Those are island.
something which is a bigger platform, just in general. But you know, whatever you have, if you have that's
Yeah.
the only thing you have open, fine, it'll work.
Also, we had.
That looks like an ILM.
I think this is when we asked for the max script, and then when she released it, that's when they opened the max script. So
This is perfect timing. You got it, and then they're like, "Oh, let's open it." And I'm like, "Oh, there goes my money." That's awesome.
Yeah, but it's always so fun to pull and remove these bands.
Till they bleed.
Hey, look at that.
Yeah. Beautiful.
But we're very happy with, you know, how it looks like under PFO here. Laser around the retinectomy.
Were you concerned about the pre-retinal blood that's there? Is that enough to leave, or are you going to try to get that out, or at this point just get out of Dodge?
I think we were pretty happy with how the retina looked at this point and really didn't go trying to remove this pre-retinal blood. And then also laser around that break we had caused, or maybe was there already. And then we put oil in this case. And then on post-op day 1, here's his pre and post-op photo. We were super happy with how he looks, but like commonly at Valley, he did not come back for further follow-up.
Hey, Karen, I'm curious. You know, it's a PDR case. How come not more laser? Like not more panretinal? That you know, I mean, obviously lasered at the edge of the retinectomy, but not why not bringing in tighter to the arcade, like superiorly and such?
Yeah, I mean, he had some pre-existing laser from before he had gotten surgery, but I think certainly we could have probably reinforced with more laser. But I think we were pretty happy with the amount of laser around the retinectomy we had.
Yeah, I mean, because your biggest, you know, my biggest concern on these is just down the road of NVI, just anterior proliferation at this point. So I think a little, you know, more laser in in this PDR retinectomies, I just find helps.
I think my thought was, let's make sure this retina stays attached. We can laser him with the oil in clinic. That was like the thought. I didn't want to put more hot laser in, and then if he reattaches, I have no real estate to save. I think the eye that is other eye was like completely detached with subretinal bands, but he didn't show up. So maybe we should have.
Good point. No, Avastin in clinic works too. I mean, that's the other option if you really needed to. So
unless they don't come back.
Well, that's the risk. These are Sunil, these are like 2 really tough
you guys
PDR cases.
What were we doing
really
during our
good.
fellowship? We were doing these.
Can I get the screen, Karen? Great job.
Oh, yeah.
Yeah, so I saw 2 large macular holes, 2 good early peels, and we have 2 outstanding peels for advanced pathology. I think that's great. Can you see my screen?
We can. How about more importantly, how about the attendings who sat on these cases and walked everyone through? Great jobs by everybody.
Most impressive.
Always a good thing. What are we doing at Academy, Pete?
What are we doing at Academy? So
on
Friday of Academy, so there's Retina Sub Day that evening at the Hotel Zelos, which is right near the convention center from 7 to 10. We are doing COBRA After Dark. Sunil, what's COBRA After Dark?
That sounds ominous. This is our second COBRA After Dark. We are going to show our second years from each institution. We're going to show 4 phenomenal cases in front of everyone. We're going to have food. We're going to have drinks. It's going to be a nice time for everyone to kind of hang out, get to see each other in person.
Rooftop.
It is a rooftop as well. So it usually is in a really cool site. It's a nice place to start your, you know, evening if you're going out later, or to end your evening if you're like, you need to go to bed, you know.
I need 12 hours a night. But please come and bring your friends, and it should be a great time just to hang out and get to meet your future colleagues in Retina.
Yeah, and then we'll have another COBRA online probably in December, January. We haven't set the date yet, but depending on how Prithvi does during COBRA after dark, we'll decide what happens after that.
If I'm arrested, I'll let you know. Wanted to thank iVista for all of their support and Bausch & Lomb for their continued support of this program, our faculty and our fellows, and the audience for staying up with us. Thank you.
Thank you very much, everyone. And we will have specialty cocktails. We'll probably have the Prithvi Cobra, I don't know, the vampire. I don't know. We'll come up with a name for it.
Lots of umbrellas, lots of cherries, and multicolors.
Definitely multicolors. Have a good night, everybody. Thanks for joining us.
Thanks, everybody.
Great cases. You guys did awesome. Very proud of everybody here.
They
nice job.
they're all complementary too. Like they all kind of fit. It was great.
I know, and it's hard to do these, and when you're showing the really hard ones, and to the first years. I mean, Lucy and Eric, nice job. Those are great.
That's scary. Yeah, the touches and the hits and the bleeding and all that stuff is it's what makes this real.
Yes, and you can feel it internally when you go over that case over again.
Yeah, that was the worst part.
I think
yes.
I hope this helps to instruct people to go back and watch their cases, right? Like I think that's essential for anybody.
I still do it. I that's what I know. I know Leanne just came off my rotation. I ask her constantly for videos that she's just done. It's more, but it's she thinks I'm like watching it. It's more for me. It's I learn from them. There's a move or a technique that we do, a decision that we make that was maybe the right one or the wrong one that you can learn from. So keep doing it.
Yeah, Jar, we need to make signature cocktails for the evening. That's the most important part of COBRA. Sunil, I got it. Don't worry, I got it.
You did it last year, and I think it was the most popular cocktail. But then, there was nobody else who could order anything because everyone's ordering I don't know, wasn't it I forgot
it was like the Viper
Venom? Red Venom or something like that.
Right.
Red Venom. Right. Yeah, Red Venom.
It was good.
Yeah, and we got to make sure that Sumit and Kat have. I'll make sure there's a drink named after them.
That'd be awesome. Memorialize you with a drink.
We should name it after the sub day the next day. I just have to make it there.
We should make it we should make it based on the fellas. Is there a theme for COBRA Live? Show us something wild.
Best case.
Worst case.
Your best case.
Just like
your best worst case.
That's different. Yeah, whatever you want. It's just stimulate discussion. I think the Cleveland crew may have already picked theirs, and we can submit this around so everyone knows what we're doing.
Asan has been working on the
endophthalmitis,
his best case to show you all freaking year. It's taken for a
it's
year.
It's gonna be like some endophthalmitis case with a rare bug that he's
the
doing
case,
in a person from
last December. He's like, Sunil's gonna love this in COBRA. Okay,
it's gonna be somebody you had to emergency get privileges on in a foreign country and had to airlift them. I know how this works.
They were in Cleveland, and then we made them come to us.
We sent them back to you guys. That's what we did. We're just like, we're done with this. You go there.
Exactly.
Good deal. All right. Everybody have a great night.
Good night.
See everybody at meetings soon.
Well done.
Thank you, George. Thank you, Elena.
Bye. Thank you.
Thank you. Good night.
Prithvi,